Good evening once again, and welcome to our second lecture in our three-part series on occupational wellness for dental professionals. Last week we had Professor Vodonovich, who presented on professional health risks, and this week we have Dr. Chingwena, who will be presenting on occupational health problems among dental professionals in Zimbabwe. So a little bit of background on our speaker. Dr. Chingwena is currently practicing as a general dentist with a special interest in pediatric dentistry in Harare. He recently completed a study on occupational health problems among dental professionals in Zimbabwe and will be presenting findings from his local research. He's also the current president of our association. Yes, Dr. Chingwena, you are free to take the stage.
Thank you very much, Taku. Good evening, colleagues. I will get straight into the presentation, a few slides to run through. Yeah, I'll just pick off from where we left off last week. I think that was more building a context into presentation for the results of the recent survey we conducted. In terms of what we are trying to achieve for this presentation, we would like to increase awareness of occupational health as a public health issue among dental professions and health professionals in general. I want to background. Okay. I will extend a bit further some of the aspects that were introduced in the last lecture, particularly around measures that individuals can take to mitigate some of the risks that are associated with acquiring some of the occupational diseases. Then will be the context in terms of our findings from the research that we did among local dental professionals. It would make more sense when we ask about them. We will conclude by proposing a way forward in terms of how the profession can approach this particular area. As per the introduction, I'm more interested in children, kids. That's what I spend more of my time studying and looking at. So why this topic on occupational health? It just so happened that a few years ago, very close to home, one of my staff started experiencing funny symptoms, numbness of the fingers, or you then start to sweat profusely during simple procedures. It's understandable if it's a difficult instruction, but even for an S&P. So after, anyway, the short of it, after several visits to different doctors, scans, and a lot of other tests, the diagnosis there was disc degeneration. I think for me that was the first profound, sorry, a bit of feedback there. All right, thank you. That was my first encounter with a really serious occupational condition or on a colleague. Short of the story, my colleague ended up deciding on early retirement. And at 49, we can say this was quite profound because you will be asking that could easily have been you. How would I survive what would be my story beyond that? So this is something that I felt could happen to all of us. And from that point, I then developed an interest to try and evaluate how widespread or how more serious this problem is among the profession, and beyond that, to try and enhance awareness among the colleagues on the potential for such incidents happening to them. It's easy when it's the next person, but then we're always saying it could be me. In terms of the concepts, the key theoretical concepts, like I said, most of them were covered last week. We have placed occupational health as being about trying to anticipate and recognize occupational health problems through some evaluation, and then ultimately developing a control mechanism for those problems that would have been identified. I think concept of occupational hazards and occupational risks was fully explored last week. In general, from general occupational health management theory, the key aspects are around hazard assessment, which is identifying the different hazards that a particular profession would pose. In our case, we look at the physical, biological, and the chemical, musculoskeletal, all those potential occupational hazards. Then you would need to follow that by performing a risk assessment. Pretty much our study is the risk assessment because we are evaluating the occupational risks among the dental professionals, beyond which you can then develop an intervention program. I think this is another framework proposed by the World Health Organization. On this one, an occupational health management program really is based on, again, risk assessment. Then you design a plan to reduce risk. We can apply this at an individual level, even in our practices. Until you have identified the risks, there's no way you can work on risk mitigation. So, as I said, just to place it within the correct theoretical context, the study was pretty much a risk evaluation or a risk assessment for the dental profession. The various hazards, I think these ones, again, were well covered in the last lecture. We know that dentists are exposed to biological, physical, chemical, biomechanical, and psychological hazards. I think this concept is fully covered. In terms of the prevalence for some of the occupational problems that then arise, you can see there, I think this is a fairly mature area in terms of available literature. Musculoskeletal diseases tend to be the most investigated area in terms of occupational health problems for dental professionals. And generally very high rates in terms of prevalence rates for those conditions. Percutaneous infections, again, lots of reports on that, a bit of reports, or a lot of reports on occupational stress. In general, this study by Prof. Modanovic, they found 97% of their cohort had one or another occupational disease, and obviously for context, we didn't have much information for Zimbabwe. So the purpose there, among others, was to sort of fill in that gap. I'll go a little bit into and quickly into risk factors for musculoskeletal diseases. I think, like I already mentioned, for musculoskeletal disease, there are quite a number of studies that are available. It's a fairly mature area, so you can find a lot of literature. I reference this systematic review and meta-analysis by Leeds and others. And they are in summarizing that paper. the major risk factors for musculoskeletal diseases would be awkward posture. That paper, the result was awkward posture. Those who are using awkward posture during their work, we have a much higher odds of developing musculoskeletal disease. Sitting and standing in one position for more than 40 minutes, I think this happens to us quite often, is another well-identified risk factor. Quite a number of papers also cite workload as a risk factor for musculoskeletal diseases. There's not entire agreement, but some papers will say if you're seeing more than 6 patients a day, you are at a higher risk, 3.2 higher odds, and some will cite a little bit higher numbers. 15, 21 are some of the reference numbers. Another key one is working without breaks. Right, that also has been seen to be a major risk factor for musculoskeletal diseases. There's quite a lot of evaluation in terms of work position, because these are modifiable risk factors. So which one is the best position to work in? Standing, sitting, alternating? I think we'll explore this further as we go, but generally seems to be an agreement that working standing puts you at a higher risk of awkward posture. So you're more likely going to eventually have the musculoskeletal problems. Most literature supports sitting and alternating your positions as you work, rather than just using a standing position. There's also literature that suggests that combining clinical and administrative work significantly increases your odds of developing musculoskeletal diseases. Running a private practice, past injuries, and another one very common in all the studies would be if you are psychologically stressed. Generally, there's a link between psychological stress and musculoskeletal pain at an epidemiological level. In terms of, I think there was a bit of reference to this in the final part of last week's lecture, issues around prevention of musculoskeletal disease. I think this is the more a developing area in terms of studies. A lot of people are still looking have been and are still looking into that area. In terms of risk reducing interventions, according to that paper that I cite, the key ones identified include adoption of ergonomic chairs, use of magnification. Everything about improving work posture, magnification, and a number of articles they support use of magnification as a risk reduction intervention for musculoskeletal disease. Instrument design, quite technical. If you
on the phone.
want to this one, things about width and the weight of the instrument can have an effect on the development of musculoskeletal disease. Then training is another area, but training in ergonomics, both in pre-graduate programs and postgraduate, like after leaving school. These are all areas that can be looked at if you are looking at risk reduction. Some of the practical aspects, like I think there was a question on the study. This one definitely supported in literature as one of the interventions that can improve or reduce the risk for some of the musculoskeletal conditions. Again, the mechanism is more around ensuring that the practitioner works from a more straight posture at the back. And these are not very costly, at least from the usual sources. I think this would be, for those who are procuring from China, I think these are ranging from $90 or so. So for the younger professionals who are setting up, you might want to start off with that and then just get used to using. So again, the key thing with the title 2 is about posture. I won't go very deep into economics. It's a whole big subject on its own. Again, it just illustrates how the different positions will affect posture and ultimately become risk factors for the musculoskeletal diseases. There's also a bit of nascent literature, which is still very embryonic, like new stuff. You will run into quite a few of these commercial prototypes for dental posture correction devices. Yeah, I think most of this literature seems to be marketing driven, so it's difficult to say exactly, but this is another option that can be considered for posture correction, fairly inexpensive as well. The traditional options, which definitely are proven, would include your loupes, microscopes. All of those definitely allow for improved posture during work. In terms of training, I think this is a big area. So you're looking at aspects to do with general, what's the practitioner's knowledge about ergonomics. And then from training, you can learn some deliberate methods around posture improvement, the issues we're talking about taking breaks during work, and stretching exercises is another intervention to reduce risks for musculoskeletal diseases. Station modification, the aspects we're talking about, use of the magnification, use of your ergonomic tools, physical activity, activities, messaging, all these have been found problems. So healing now becomes an issue in the fraternal community as well as in the curriculum for undergraduate programs. There's quite a bit of interest in stretches. Definitely the literature support. I think where there's no underlying serious condition that would need probably a physician-directed approach. Things like neck stretches before and after work, back stretches, hand stretches, all have been found to be helpful and are supported in literature. These are approaches that we can consider at an individual level. We just scratched on this study into occupational stress because it's such a big topic. But from our knowledge, we already know that there are several factors that have resulted in dentistry being one of the higher or more stressful professions. And these factors will range from your professional factors, income. I think this is more relevant, number of patients, perhaps less or insufficient numbers, like we said, the number of patients too little. Then anxious patients, so the context, the word context is just stressful. Dental procedures are also stressful to carry out. You may also have financial pressure and factors to consider around office management. The occupational stress is another of the big occupational hazards that we considered for the study. Now I'll then go into the actual study in this section, and the following one I'll just focus on our findings and how we and what we can make out of the local study that we carried out. For this particular study, the main question was to find out what the major occupational diseases and risk factors are among the dental professionals in Zimbabwe. Key among them, to establish the burden of occupational diseases, the risk factors, and we also wanted to explore to what extent the local professionals have adopted prevention measures that are available for the various occupational conditions. Basically, we carried out a cross-sectional analytical study as a national survey, including basically all the dental professionals we could reach who are practicing in Zimbabwe. In short, that was the essence of the methodology that was used. Like I said earlier, we used the census approach. Our minimum number of respondents was calculated at 97. I think I won't go too much into these details, but we used this a self-administered questionnaire and distributed an online version of the questionnaire. And I think all the other ethical aspects were fully covered there. In terms of the results, I'll just go briefly into those results. I want to do a very extensive to summarize the key findings there. In terms of demographics, ultimately, we sent out about 323 questionnaires. The study was covering both dental practitioners and dental therapists. We had 211 responses, but 72 had no data. I think these ones did not consent, and ultimately we had 134 response or questionnaires with responses that we then used for the actual analysis. I've just summarized some characteristics of the participants. I think generally fairly representative of the demographics of the practitioners currently in practice in Zimbabwe. Most of the practitioners are qualified in Zimbabwe, and majority were in private sector, although with quite a number that both in public and private sector. In terms of categorization of the participants, if we look at the distribution by employment of the respondents, like we said, 102, the majority were in private practice, quite a sizable number in the other areas of practice. And with regards to the work characteristics of the participants, in terms of patient loads, you can see that, quite a range in terms of patient loads. The most common is 4 to 6 patients a day. A few that also see 7 to 8. And there are others that see more than 8 patients a day in that cohort. Most of the practitioners work 5-6 days. Probably 1 or 2 that work every day. In terms of the characterizations there, I think most of us can identify with those ones. In terms of the key numbers, in terms of musculoskeletal pain, 83%. So this is quite a common problem among the dental professionals. 83% reported that they have experienced musculoskeletal pain. This is the usual marker for beginning of or presence of musculoskeletal problems. In terms of colleagues that have now developed the chronic musculoskeletal diseases, that was about 16%, of which the most common was back pain, lower back pain. That was the most common. Otherwise, the other number was spread out among different conditions. Although the most common by far is lower back pain. And occupational stress, that was second highest in terms of the prevalence there, 58% self-reported occupational stress in this case. And the other findings, percutaneous injuries, 27% were reporting that they had suffered percutaneous injuries, so fairly common. And allergies for me were a bit of a surprise. I thought this was a much more common problem, but for the cohort, we had 7.4. And ocular injuries were reported much less common at 3.6%. These are the key numbers in terms of the overall findings of the study. We're just zoning into a few aspects. In terms of musculoskeletal pain, the most common areas for musculoskeletal pain, in general, if we look at for 12 months, it was the neck area. And then also you get the lower back and neck, but otherwise a whole range of areas. People who have shoulder pain, you get upper back pain. Yeah, 83%, like we said, was the overall number, which is quite high. In terms of the impact of the musculoskeletal pain, we checked if there was impact on work hours, absence from work, and need for medical care, or increased use of analgesics. And in all these cases, it was said there was a statistically significant effect of the pain. So the pain was consequential, if I can summarize that. Although majority were reporting it as mild in terms of the actual grading of the pain. Another aspect is on adoption of preventive measures. We assessed level of training in pre-service programs, and 74% were reporting they had received training in ergonomics in their pre-graduate training. So that sort of points a bit of a gap there. 26% who said they didn't get any training on ergonomics. Physical exercise is a preventive measure. It's like your recreational physical exercise, high adoption there. I found this to be weird. I suppose there may have been a mix up of what the ergonomic or SADO is, but the data was suggesting 43% have adopted the ergonomic or SADO too, but my suspicion was that there may have been confusion about what the ergonomic tool is about. Then post-graduate or exposure to economic training after graduation is much lower. This was 18% had received some sort of training after graduation. In terms of adoption of these other tools, loops, 16%, straight afterward, 15%, and then economics training in the last years was only 1%. So probably your other points did not with that need for retraining or updating. I think it's already interventional that we have developed the occupational health series like this one. As it covers both aspects of feedback and retraining. In terms of the risk factors, a bit of a more complex with over 36 possible risk factors to look at. And the key ones for musculoskeletal pain, the demographic ones, which is significant with age. I think in general, it was protective there when you do your multivariate analysis. And the other one I wanted to point out was type of practitioner for musculoskeletal pain. we were getting a much higher odds. Although there was a bit of statistical considerations because our sample for dental therapists was a bit lower. We had 36 dental therapist responses, but the odds for musculoskeletal pain seems to be much higher, although we can interpret this with some caution, but it was much, much higher. This is a very big number. Multiple models were still giving very big numbers. Just zooming into that one, odds of 60 there for dental therapists when we compare to general dentists. The other aspect was work-related factors, the ones that were positive for us there in terms of the local risk factors or risk factor analysis, were work position, and where we are pointing there standing. You have increased odds of developing musculoskeletal pain if you work standing. You can see that these ones are protective and significant. Yeah, working in one position for more than 40 minutes again, that was increased odds for musculoskeletal pain, significant there. The other one is self-reported occupational stress, again, was much more increased odds of musculoskeletal pain with self-reported occupational stress. I think, my apologies, are fairly busy slide, just a second. In terms of those who already have confirmed musculoskeletal or chronic musculoskeletal diseases, again, the risk factors were fairly common with other studies: age, preferred work position. Again, you see standing, increased odds. Alternating is protective in this case. Posture, again, awkward posture increases the odds. So fairly consistent. I think we can almost use that what our risk factors are fairly consistent with what we find in literature. In terms of, for just a quick summary of our results in the other areas, in terms of percutaneous injuries, we've already said the number there was prevalent of 27%. Of note, 79% responded that they had received hepatitis vaccination, which means that we had a gap of about 21% who had not received that vaccination. The common causes, I think, fairly consistent. Knee to prick injuries, the most common, child bites. And then you have a whole range of other causes for percutaneous injuries. But I think this way, anyway, we will see how they compare with other studies in the discussion. Use of PPE, I think, generally high, although it's surprising that not everyone said they use gloves. Protective masks, is very high. Shields, fairly high. Protective glasses, I think this one, nothing unexpected there. In terms of adoption of optical devices, quite a high number. They were saying they do not use any optical devices, 77 of the respondents. Now with your low levels of ocular injuries, but then a very low adoption rate for optical devices. Non-magnifying goggles, much more commonly adopted, and then I think we had already mentioned only 2 reported using microscopes. In terms of eyewear, quite a number there. The highest number not use optical devices. Some will use, but rarely, and only a very small portion use optical devices all the time. Just a few slides. I think I'm getting close to, I'm still on time, to the end of the presentation. In terms of occupational stress, like I said, occupational stress, it was a difficult topic to evaluate, mainly because there are lots of confounders in terms of is the stress that people are experiencing because of mental, is it because of the economy, or is it because of other issues? So we ended up focusing on just self-reported occupational stress in this case. And we already indicated 58%, which was quite a high number. And the effects of the stress, a whole range. I think the speaker for next week might go into a bit more detail around this. But the common things include frustration and anger, fatigue and exhaustion, tiredness. Quite a number reported they were depressed, anxiety, burnout. All of those are common effects of occupational stress, which our colleagues reported. In terms of the major factors that the respondents ascribed the pain to, professional, the biggest was low income. In a lot of work is too little. I think many of us can identify with these issues. On patient factors, the most common consideration patient and corporate patients. Mental procedures, the drive for perfection, and then keeping up with new developments were the main factors contributing to occupational stress there. And the biggest one of all is financial pressure, which is quite understandable when you consider the operational matrix. In terms of coping strategies that the respondents adopted, there are several that we evaluated. Some include, I think the most common would be like you taking rest and breaks. That's the most commonly adopted. Interacting with other people. Prayer is a common one. Is a stress coping strategy in our group. Taking up different hobbies, exercise and sports. There were also some destructive ones. Alcohol, I don't know whether it's destructive or not, but it's another coping mechanism that people had adopted. 20% of the reported. I think in general, yeah, there are quite a lot more cases that are appearing within the profession, especially at the council, medical and dental practitioners council, practitioners being put under health surveillance. And yeah, this is a problem that the profession will have to keep looking at and see how we emerge out of it. Just a few slides in terms of just some analysis and comparing our findings with other literatures. We note that there was a high number of non-consenting respondents. Maybe some people did not feel very secure about the maybe that information might be identified with them. I'm not too sure why we had a fairly high non-consent rate. Overall response rate was 43%, which I think is fairly representative in terms of the sample size. We note high musculoskeletal pain, which is 83%. This is comparable to the other statistics we have. Nigeria 76%, South Africa 79%, European studies 81% is a summary. Then in terms of the risk factors, you will note that they were fairly in common with other studies. Things like awkward posture, weight position, links between self-reported occupational stress and musculoskeletal pain. It's in common with other studies.
So do you want to bake potato
in this case, we did not establish workload as a risk factor. Yeah, probably in Zimbabwe, our workload perhaps may not be as high as in other countries due to financing reasons. And pectineous injuries were 27%, which was lower than other regions. A Greek study, they reported 73%. The Croatian one, it was 49%. So this was slightly lower, although the Nigerian one was reporting 18%. So perhaps in this region, pectineous injuries are not as big a problem. Occupational allergies, as I mentioned earlier, was very low, was relatively low, or at least I expected that they would be high because I have that problem myself. Some are reporting as high as 76%. This is the European study, although this one from UAE was 18%. So maybe there may be a possible ethnic basis for the difference. I'm not very sure about that. Occupational stress, 58%. Yeah, this one is comparable to other studies and not very surprising given the economic situation in Zimbabwe. So by conclusion, we can say the dental professionals in Zimbabwe are facing markedly high occupational health problems. There's significantly high levels of musculoskeletal problems. The dental professionals are exposed to significantly high levels of psychological hazards. There seems to be inadequate uptake of preventive measures. And also there's a gap we noted about protection against biological risks like hepatitis B. So by way of conclusion or just summarizing the survey shows that there is need to monitor these occupational health and respond accordingly, affected members, and really enhancing awareness about the risks as well as the possible prevention mechanisms. There's a case for creating a surveillance program or a database for members affected by occupational conditions and then offering appropriate support to those members, a case for periodic surveys, and then generally we recommend higher advocates for occupational wellness of the dental professionals, as they clearly on the argument about placing dentistry as a dangerous profession, put it at the same level as the artisanal miners. And the argument would be you are mining in different areas, but you are equally exposed. I would like to end by just acknowledging a few of my co-researchers. We included Dr. Maponga, who's my brother-in-law, and Dr. Montgomery from African University. I also had quite a bit of mentorship from Prof. Bodanovich for this particular study. And I would like to also appreciate all the colleagues who took time to respond to the study. Otherwise, some references, some of the key ones, we include this one. Litsi is a very good one if you want a summary on both the risk factors as well as the prevention factors. This one also is very good in terms of assessment of risk factors and preventive measures as well. Otherwise, that would be a summary of the presentation. I thank you.
Thank you, Dr. Chingwena, for your presentation. I think it is encouraging when we see our own members contributing to the body of knowledge. So this time we will take some questions from the membership. If there are any questions, you can type them into the chat, or you may raise your hand or unmute yourselves. While we're waiting for questions from the membership, I have one that I would like to ask you, Dr. Chingwena. Not so much on your presentation, but maybe more in line with the recommendations. Is there, I mean, in Zimbabwe, is there, or are there insurance companies or any sort of systems in place for occupational related insurance. So for example, if we as dentists or dental therapists injure our hands, is there such insurance available? And if so, how does one go about it?
All right. Thank you for that question. I think it's open to everyone. I would not claim to be a guru in the area, but my little knowledge is if there are any products, they are probably very few. I haven't come across a privately offered product for that specific purpose. There may be some insurance that cover hospitalization or being away from work. I think there was a time when Eco Insurance was offering some cover for if you get admitted or cannot attend work, and then they will pay some sort of amount. I don't know how much that's off. However, the main cover for occupational problems in Zimbabwe is by NASA, the National Social Security Authority. They do have a department. I have an experience with my colleague who had that occupational problem, and they would do a process to evaluate whether the questions are always, is it an occupational injury or is it not? That will be the first question that you need to assess. So you need to prove that really it is an occupational injury. And then once it goes through, you will need a disability quantification. I think there's some process that's done by NASA, and then you get some sort of disability benefits from NASA. That's as far as I know. I'm not aware of any other products, but if colleagues are aware, I'm sure they can share.
Okay, thank you for your response, Doc. We have a question in the chat from Dr. Chifamba. It reads, thank you for your presentation. In your study, did you come across dental professionals affected by carpal tunnel syndrome or similar conditions caused by repetitive action of the wrists? Do you have any suggestions on how to mitigate against that given the wide use of hand instruments?
Thank you again for the question. Let me just see if I make out the question again. Carpal tunnel syndrome, for our sample, we didn't get any that we're reporting that particular issue. I think the major ones, like I said, we got with chronic back pain or lower back pain. There were some that were reporting spinal disc herniation, some that may have been associated with some injuries, spondylosis, scoliosis, meiosis, all those sort of conditions were the ones that we got positive responses about. In terms of the mitigation for, let me just see again the question in terms of caused by the recent repetitive one. At the moment, I don't have any specific suggestion, unless someone from their experience would propose something. But I must say I didn't come across we didn't come across any cases that we're reporting carpal tunnel syndrome. Although this is definitely one of the risks.
Okay, thanks, Doc, for your response. We have a question or a comment from Dr. Makoni.
Hello, thank you, Dr. Chingwena, for that presentation. Very interesting study. Maybe I missed it, but I'm just wondering whether there were any findings to do with audiology, with hearing issues, since we work in such all those noises around us, did you pick up anything in your study or as you did your literature search? And then my other comment is on the ergonomics. The responses seemed to indicate that amongst your respondents that there'd been no or very little undergraduate training in ergonomics. I may have missed that. So if you could just come back to that portion, maybe I didn't hear properly because it kind of got me concerned. Because for those who graduated at UZ, that's part of everybody goes through that before they start their restorative dentistry. So I just wondered if I missed your explanation on that point. But otherwise, thank you so much. Very interesting.
Thank you, Doc, for the question. I think we did say yes about, that was 20% were indicating that they had not received any ergonomic training, but our sample included people from our professionals from diverse backgrounds, which include among the dentists 28 who were not trained in Zimbabwe, as well as 31 or 36 dental therapists. So I'm not too sure what the level of training in ergonomics is in those spaces. I think that that would be perhaps a response to that particular aspect. I don't know if I have fully answered on the audiology. That one is a tricky one because one, for you to do a valid study, you would need for audiology, you would need to use some measuring techniques or hearing evaluation techniques. We do not have capacity for a hearing evaluation or a hearing evaluation test for this particular studies. There's no self-administered tool that allows for a valid audiology assessment. So that was one of the problems why we didn't end up looking at that particular factor. The other issue from the existing studies, they have seen, let's say, comparing dentists with medical practitioners. They have seen fairly comparable hearing results in terms of the dentist, for the papers that I found for the dentists and medical practitioners, although there were slightly more issues on the dentist or on the dental professionals group. What they concluded for one of the papers was that age is a more important factor than profession in terms of developing gradual hearing impairment. I hope I have answered the question, Doc. Hello, Dr. Makoni.
Yes, sorry, I was failing to unmute. Yes, thank you so much. I guess, as you have explained, the hearing one would be problematic to evaluate. So thank you very much. I was just wondering whether it's age kicking in or it's these gadgets that I seem to be not hearing as well as I used to 20 years ago. So thank you so much.
Thank you, Doc. I'll give you a referral for an ENT. I'm joking. All right.
Thank you. Do we have any more questions from the membership? Okay, if not, our time is 6:30 and we'll close this session. Thank you very much, Doc, for your presentation. Next week, we will be having the last part of this lecture series from Dr. Anesu Chinoperekwe.
Thank you.
Okay. I'm sure the recording will be made available on the WhatsApp platform. And if there are any more questions for Dr. Chingwena, I'm sure he can accommodate you in his inbox. Having said that, I'd like to close this meeting. Have a good evening.